Elimination. Ordinarily, our patients are able to take care of urinary and bowel elimination on their own. They consider this to be a very private process, but it kind of depends on their age, their health status, and their developmental stage. Some patients are going to require some psychological support when there is a change in how they pass their waste. These changes might be surgical or medical. We have to remember that monitoring output can reflect client health status. Common causes of constipation, there are a large variety of them out there. Some of the chronic illnesses would be Parkinson's, multiple sclerosis, rheumatoid arthritis, chronic bowel diseases, depression, eating disorders. Some of the neurological conditions would be a spinal cord injury or a tumor. Some organic illnesses would be hypothyroidism, hypocalcemia, or hypokalemia. And different medications can also cause constipation. Your anticholinergics, they dry you out. Antispasmodics, anticonvulsants, antidepressants, antihistamines also dry you out. Antihypertensives, antiparkinsonism, bile acid sequestrants, diuretics, antacids, iron supplements is a big one, calcium supplements, and opioids. We always look at their medications to see if that might be an issue. If they are on any type of narcotic pain reliever, then we really need to consider possibly changing medications. When we are addressing chronic constipation, we really try to go with the conservative methods first. We want to start with lifestyle changes, beginning with increasing their fiber in their diet, increasing their fluids or their exercise. And if they are a chronic laxative user, we need to try and get them off of that, although those bulk laxatives can be very effective. We need to realize that if a client is having some fecal incontinence or some diarrhea, that they may actually be impacted. In other words, they are very constipated. Um, so don't think that just because they're having a loose, runny stool that they're not constipated. Functional constipation will be two or more of the following factors that are lasting at least 3 months in duration. Straining with defecation at least a quarter of the time, lumpy or hard stools, or both, a quarter of the time, feeling like they're not completely emptying out their bowel a quarter of the time, or 2 or fewer bowel movements in a week. Encourage the client not to ignore the urge to defecate. If they're immobile, we may need to utilize a bedpan, and make sure that you choose the right one. The picture that you have here is your standard bedpan, but they also have fracture pans that are a lot flatter. So those clients that may have a hip replacement or a hip fracture, those would be the type that we would want to use with those patients. But we need to realize that a lot of people are just unable to void or defecate in a bedpan. But irregardless, we need to make sure that we're providing good perineal hygiene. So let's look at the opposite end of the spectrum. Let's look at diarrhea. There are several different use or possible causes of diarrhea, which would include antibiotic use, infections, parasites, an impaction, or chronic bowel diseases. A lot of people who have diarrhea have some type of fecal incontinence, and this does cause client embarrassment. It's very odorous, and they have a mess. Make sure that we're providing good perineal hygiene and monitor their skin integrity. Diarrhea tends to really eat at the skin of the perineum. This is a chart that just shows you some of the differences in the types of stool that will show you, how much the client is having to strain. So I would say type 1, type 2, type 3 even. They're probably having to strain quite a bit to pass that stool. How do we remove fecal impaction? No, we don't use explosives like they're doing in the cartoon, but basically we remove it manually. Obstipation is the absolute inability to pass stool. Symptoms will include constipation, discomfort, anorexia, nausea, vomiting, pain, diarrhea, and urinary frequency. The stool that is in the rectum is actually putting pressure on the nerves that make a person feel as though they need to void, so they're going frequently. We need to realize that excessive rectal manipulation can cause not only irritation of the mucosa, which would also lead to bleeding, but it can stimulate the vagus nerve. So it is contraindicated in cardiac clients. To remove a fecal impaction, we usually position the client on their left side and make sure you provide privacy. Put on clean gloves. An anesthetic lubricant would be nice. This is a very uncomfortable procedure. You insert 2 fingers, your index finger and your middle finger, and using a scissor-like movement, you're going to break up that stool that's in the rectum and then manually remove it. Make sure that you're keeping an eye on the client throughout the procedure and perform perineal hygiene when you're done. Some patients require some bowel retraining. They have problems with, maybe it's incontinence, or maybe they have a problem with constipation. So if we develop routine times for them to sit on the toilet, then sometimes this will encourage them to go at those times and their body gets accustomed to it. Don't encourage the client to sit on the toilet for longer than 30 minutes. Or 15 to 20 minutes, and usually we put them on the toilet about 30 minutes following a meal. If they lean forward and put some pressure on their abdomen, this will help stimulate that stool to move on through. We don't want them to strain as they're bearing down. Stool softeners are definitely okay, and sometimes they need a suppository to kind of help get things going. Hot fluids or fruit juices are very helpful for this also. And we also need to encourage them to avoid those opioids. But sometimes even then that doesn't work, so we need to administer an enema. Enemas are not just for constipation, they are also to clean out the bowel for specific procedures. But it's basically an installation of a solution into the rectum and the sigmoid colon. The type of fluid or volume is going to help break up that mass. It might soften it, it might stretch the rectal wall, but basically the end result is initiating the defecation reflex. Enemas stimulate peristalsis. They have several different types of enemas out there, and you need to make sure that you refer to your order and use the appropriate ordered enema for the patient. They've got cleansing enemas. Those are done for patients that are maybe going to have a colonoscopy. Oil retention enemas, they lubricate the rectum and the colon, and they will help a patient be able to pass a stool. Medicated enemas may contain medications in the fluid itself. Tap water enemas, basically just water from the tap, but we need to be sure that we don't repeat those unless we have a very specific order, because it can cause water toxicity. Physiological normal saline, in other words, it's basically the same as what is in our bodies. We use that with infants and children's. Mix 500 mLs of tap water with a teaspoon of salt. Hypertonic are good for those clients that cannot tolerate a large enema volume. For example, we have the Fleets enema. It's a very small volume, but it really does the job. A Harris flush is a return flow enema that's going to help expel gas. Soap suds, usually the enema package will come with the soap suds in a little packet. Carminative and milk and molasses. That's one of the many home remedies that some of your physicians might have up their sleeve. I've used milk and molasses enemas and they are very effective. How do you do an enema? Well, again, it's contraindicated in clients that have that cardiac disease because it's going to stimulate that vagus nerve. It also causes issues with clients that have increased intracranial pressure, glaucoma, recent abdominal, rectal, or prostate surgery. If you have an order of enemas till clear, that means that the enemas are continually repeated until there's no longer any fecal matter coming out in the return. Does not mean it's going to be clear like fluid, like water, but it's going to be very runny. It may have a color to it. It may have a few flecks, but it's not going to have large amounts of stool in it. Make sure that you get all the equipment that you need before you go in to perform the enema. If the client is immobile, you may need to have a bedpan or a bedside commode, depending on the degree of their immobility. Prepare the enema per order. Make sure that you warm the fluid. Cold fluid can cause some significant issues. Put the client on their left side. Think about how it's going to go up into the body. It's going to follow the laws of gravity, and you're wanting to usually clean out the lower portion of the colon. Protect the bedding and make sure that you use lubrication. When you're inserting the tubing or the nozzle, aim it towards the umbilicus after you expel the air. Make sure the client is breathing slowly. If they're breathing rapidly or too deeply, they may be putting pressure on their abdomen and may be causing them to bear down. If the tube is not going to pass very easily or the patient complains of pain, you need to stop immediately. Make sure that you instill the fluid slowly. If the patient complains of some abdominal cramping, it's usually because the fluid is going in too quickly or the fluid is too cold. So slow down the fluid rate, and you can do that by raising or lowering the enema bag. If you raise it, it's going to go faster. If you lower it, it will slow it down. When do you know when to stop? Well, if all of your solution is gone, or if the client says no more, or if the solution begins to leak out of the anus. You want the client to be able to hold that solution in the rectum as long as possible. It will do more good the longer it's in there. Some people can do this. Other people, as soon as you pull the tube out, they're ready to go. Assist the client as necessary to the toilet or commode or with a bedpan. Now, there's some problems that may require a surgical intervention, and the physician has to create an opening into the abdominal wall to drain fecal or urinary matter. This opening is called a stoma, and it's built from a section of the colon or the small intestine. Depending on where this opening is placed is going to let you know what kind of effluent you're going to have coming out of the stoma. If the colostomy is placed in the sigmoid or descending colon, you're going to have a stool that's pretty similar to what is normally passed through the rectum. If you have a colostomy in the ascending or the transverse colon, the stool is usually a pretty thick liquid, to maybe a semi-formed stool. If you have an ileostomy, which is placed in the ileal portion of the small intestine, it results in a watery to a thick liquid, and it may have some digestive enzymes in it also. An ileal conduit or urostomy will take a resected piece of the ileal portion of the intestine, and it connects both ureters to it, and you usually will see mucousy urine as the discharge. There's a lot of psychological concerns when clients have ostomies. They have concerns of social rejection, their concerns over sexual function and intimacy, a need for assistance with personal care, or leakage or odor. These types of fecal elimination devices are very odorous, and you need to make sure that you maintain a very professional attitude. Yes, it may make you want to retch. Yes, it may gag you. You wrinkle up your nose, and you really have to school your features to show absolutely no emotion, because your patients are going to be watching this and they're going to be offended, or it's going to affect them psychologically. So make sure that you really are prepared. You need to be able to assess the stoma. It should be pink or red, and it should be moist. If it is gray, purple, or black, report it immediately, because it means that there's some type of circulation problem. There's different types of stomas. You may have one that extends out from the abdomen itself. You may have one that's a little bit retracted or flush with the abdomen. But you need to assess the stoma. Make sure it looks good. Also assess the skin around the stoma and assess what type of effluent is coming out of it. The skin around should be intact. It may be slightly reddened, but you don't want it to be raw or have blisters or a rash. And make sure that you know which type of effluent should be coming out of the ostomy, so you know if it's normal or not. Make sure that you place the pouch on clean, dry skin. And if it's done appropriately, then it's going to protect the client from drainage and provide a barrier against odor. If a pouch is leaking, you've got to change it, and make sure that you don't let it get too full before you change it. Never, ever, ever tape an ostomy bag if it's leaking, because it's only going to result in skin breakdown. You need to take it completely off and start all over again. Never dispose of the clip that comes with the bag unless it is so soiled that you cannot get it clean. The bags do not come with a new clip every time, so that clip is often reused if it's the style of bag that uses a clip. Once you get the pouch in place, you should hold your hand over the barrier. It helps seal with the heat of your hand. Those adhesives on this type of seal is actually heat activated. There are some commercial adhesives out there that may assist in that barrier adhering, such as Skin Prep or Mastisol. Now, irrigation of the ostomy is no longer a popular practice. It used to be done quite often, but we just don't see it done very often anymore. It can be done to help regulate that colon, or in case someone who has an ostomy has constipation. It requires an irrigation cone that is actually inserted into the stoma itself. You instill the fluid through that cone into the stoma just as you would with an enema. The client has a particular drainage sleeve that actually hangs down into the toilet. So they do this while sitting on the toilet. And it can take about 30 to 45 minutes for the return drainage to stop. So they're going to have to sit there for a little while. Again, this is not a popular procedure any longer.